Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Apria. Having a site visit can be a bit nerve-wracking. We want to make sure that all of our policies and procedures are in order and that we haven't overlooked anything. I think we all assume accreditation is important, but how much of it do we really understand? Why are the standards what they are, and who decides this? How often do the standards change? What are the upcoming changes in 2025, and how should we prepare for those changes? Dr. Fady Jamous is chair of the AASM Accreditation Committee. He is a pulmonary, critical care, and sleep medicine physician in Sioux Falls, South Dakota. He is accompanied by Anthonijsz, who is one of the AASM staff members responsible for the behind-the-scenes work of the committee. They are here today to provide a glimpse behind the curtain and to help explain some upcoming changes to AASM accreditation standards that go into effect in 2025. Thanks for joining us today.
Thank you.
Thank you, Dr. Khosla.
So let's level set, Ray. What is accreditation and why is it important?
Accreditation. So accreditation, the way I like to describe it is that it's a voluntary activity that provides recognition that an entity has met rigorous standards set by an accrediting body. So in this case, we're talking about AASM accreditation, and so AASM is that accrediting body. So we have set standards to which an entity submits an application for us to determine whether they are compliant with our standards. All right. Now, it's important for two reasons. We talk about from a voluntary aspect, and so first and foremost, it's an indicator of care. So it's an indicator of care to patients, it's an indicator of care to referring providers, and it's an indicator of care to payers. And payers would be kind of that required aspect then when we get kind of into that second reason, because CMS now in all 50 states has some sort of accreditation requirement in their LCDs. Many private payers also follow suit to having an accreditation requirement in their reimbursement requirements. And so it meets those needs for an entity to be able to receive reimbursement when they are submitting for a particular type of service or test.
So is it mostly about payers, or are there other accreditation standards?
Well, from the two aspects, payers certainly want to make sure that for them to be able to get reimbursed, we want to make sure that we are meeting those payer requirements. Now, there's a number of payer requirements that they put out there. Accreditation is one of those payer requirements. And so being able to at least meet that requirement allows them to receive reimbursement as long as they also adhere to all of the payer requirements that they need.
So are there some key accreditation standards that we should know about?
Yeah, there's a number of key accreditation standards. I think from AASM standards, we have board certified sleep specialist. I would say that's going to be a key standard. Patient management is another key standard. From the AASM's perspective, making sure that we have involvement from a board certified sleep specialist, that we have patient management, meaning the long-term care following the testing is important. That's how we can make sure that we are able to provide high-quality, patient-centered care.
And is that also where the part about seeing non-OSA patients comes in too?
Yes. So from a standard perspective, we talk about making sure that we're able to provide an adequate range of care for our patients. And so that would be more than just OSA.
So, Fady, you can help me with this. Who decides what the standards are?
So it's a process, and there's been history. and things have changed. When we were talking with Ray recently, the accreditations themselves have gone through many iterations. The main ones have happened in 2014 and then 2016. There's been a few updates until the ones that are current, which were adopted in 2022. But the ASM realized that there's evolution in the
Mm.
practice of sleep medicine. Um, Larger hospitals, physician groups, multiple clinics, and even smaller practices that are able to leverage technology and expand their reach with less need for physical infrastructure. So the standards needed to evolve to accommodate all those different practice models. And one of the missions, the mission of ASM is to advance sleep care and enhance sleep health and improve lives based on that. And one way to do that and improve the quality care is by accreditation. And so, in a sense, having accreditation standards, it's a guide for all of us. If we're able to meet those accreditation standards, then we know that we are providing good quality care. It's one of those tools. As far as how the current standards came about, there's input from a lot of entities within ASM. From the accreditation committee standpoint, a draft was presented to us, and over a period of a couple of years, we went line by line, compared the current one to the previous one, voted on changes until we came with the current one. There was a period where the public was able to provide
Mm.
input, and every input, every comment we reviewed and made changes or not, depending on what we thought the spirit of those standards were. And at the end, the standards are presented to the board and they get voted on.
Oh wow, so it's a lot more involved, isn't it?
From a accreditation member standpoint, it was very, very hard work, detail oriented,
Hmm.
and the accreditation committee has 10 members and they represent all types of sleep practices. And between nurse practitioners, also to physicians, to respiratory therapists, it was always very interesting, and I learned a lot just having those discussions as we finalized those standards.
So is there sort of this overarching theme or like a guiding principle to in terms of why the standards should be what they are?
The primary purpose really is to assist all of us to provide the highest quality care that can be delivered to our patients with sleep disorders. It's always been the focus of the standards on the lab itself.
Mm.
A few years ago, the focus changed to where now it's clinic based. Um, and a few years ago, there was recognition that many centers are linked together, and so a corporate model was provided, but it wasn't good enough
Mm.
to meet the challenges of what's happening in the practice of sleep medicine and sleep medicine delivery of care. And what really has changed is the ability to have this network
Mm.
of multiple labs, multiple sleep studies, sleep clinics, multiple home testing that can communicate with each other or work together to provide the best of care. And the new model of accreditation will allow this to happen, whereas the previous one was pretty rigid.
I mean, when I hear you say that about networked systems, I think about the big systems, but then I also think about closer to home for me, where we have little labs, 2-bed lab here and a 2-bed lab there, and so
Mhm.
is that part of that network that you're talking about?
Definitely, and that's exactly what personally I'm hoping to be able to, provide to rural communities. The ability of a two-bed lab or a home sleep apnea test
Mm.
facility to link up with a larger clinic, link up with a larger lab under some kind of a directorship or a formula where a sleep boarded physician and maybe multiple sleep boarded sleep physicians are able to be assisting in the care of those patients with small labs. It would have been very difficult for centers to do that before.
Hmm.
We're hoping that the new standards would allow that to happen.
So help me understand this better. I mean, I get that a payer policy and ASM accreditation are different, but they seem kind of related. So what's the difference?
We follow Medicare rules, and there are different regions. And the Medicare does have a minimum,
Mm.
a description of what a lab should be, a minimum description of who the physician should be reading a sleep study, and a minimum definition of which type of technologist can be present during the polysomnogram to be paid.
Mm.
The ASM standards elevate these a notch. And so while the payers do have their criteria, ASM feels that there are certain additional quality measures, if provided, hopefully will result in improvement in quality of care. And this is to go back to what Trey was mentioning earlier. What differentiates ASM requirements is going to be that sleep boarded physician,
Mm.
particular requirements in reference to the sleep technologist, possible physical requirements for the sleep lab, etc.
So is this kind of like when I think about the difference, is this kind of like the hypopnea rule where you have the CMS sort of rule for hypopnea and then you have the ASM rule?
Yep, and that's a very good example. In the preface of the accreditation, we one of the requirements is to follow um, all strong and standard level recommendations that are in statements that are generated by the ASM, like clinical practice guidelines, practice parameters, clinical guidelines, clinical guidance statements, and best clinical practice papers. So the 3% rule kind of comes through that, while not specifically, mentioned in the standards, but everything that is strongly recommended by ASM, and also, with lesser quality or lesser strength, I mean, is expected of those labs to follow. So to answer the question about the 3%, I mean, yes, it is expected and will be part of the accreditation standard to follow the ASM rules in reference to the 3% for diagnosis of hypopnea.
So let's talk about some of these new changes. So it's my understanding they go into effect January of 2025, but won't be enforced until January 2026. So what does that mean?
Yes, so the new standards, they will take effect January 1st, 2025. And then we're giving all of our accredited programs a year to become compliant.
Mm.
Ultimately, what that means is they have a year to make sure that they are, whether they need to maybe change some operational policies or things like that, but to ultimately become compliant so that by December 31st, 2025, ultimately January, the beginning of 2026, that they are compliant to the new standards.
So that's really helpful because I think it's scary to hear about all these new rules going into effect in
Yep.
January of 2025,
Yep.
right? It's nice to have a little bit of grace.
Yeah, and actually, if you wouldn't mind, just to highlight something that we were talking about a little bit about earlier, which is kind of this overarching theme. When we think about the implementation of the new standards coming out January, I just want to make sure that we also understand that, from a standard perspective, what the committee was tasked to do was to be able to make sure that when we're reviewing our standards for January, that they were quote unquote, the kind of the objective that was given to them was to remove barriers as long as it did not affect the high quality care of the standard. And so when we think about compliance to these standards, especially from our current practice of things, they really are designed to make sure that we're removing those barriers. We're not creating pain points, but we're removing those pain points. And so compliance with these standards really should be easy for our centers to do
Oh, I love to hear that.
that.
So so let's talk about the sleep tech rule. What has changed?
So with the sleep tech rule, the standard that ultimately talks about the registered technologist, that principal registered technologist, the requirement for them right now is that they need to be present at the lab 30 hours per week, and then it goes to say, if they've been open fewer than 40 hours per week, then they need to be present 75% of the operating hours. In the new standards, the operating hours actually don't change. But what has changed is when we talk about being present, now we allow for the capability of being present virtually or in person. So that begins to improve access for those registered technologists, especially in areas that would be rural, where they're having trouble being able to either find or they have to travel a long distance to be on site. So it begins to open up access to registered technologists.
So to me, that's a huge one. So if I'm understanding this right, it's like a remotely attended study. So you have an RPSGT centrally, but then you have a physical person at the bedside still, a trained person.
We actually don't necessarily talk about the responsibilities in the standards that the registered technologist has to do. So when we talk about this principal registered technologist, we really just kind of ultimately, from a standard perspective, indicate that they need to be present a certain amount of operating hours. Now, that means then a registered technologist that is fulfilling that role, maybe they're conducting studies, maybe they're simply just involved with the scoring aspect of everything. Maybe they are or I should say maybe manager, where they're just more involved in the operations of the day-to-day activities. And so as long as they have that involvement for what is the requirements of the operating hours, then they are adhering to that standard.
Oh, wow. Do they count when you're trying to figure out the tech ratio? Do they count?
So when we think through the ratio, basically the patient to tech ratio, the standard talks about a recommended ratio of 2 to 1. So 2 patients to 1 technologist. And so if we think through that standard and the recommendation actually hasn't changed with the new standards. And so the intent of that standard, and I think this is something that, from a committee level we talk about, and I'm sure Dr. Jamous has thoughts on this as well, but we talk about kind of, what is the written standard, the intent of the standard, maybe the background and the context. So the standard itself, when we talk about the patient to tech ratio, that standard is written with the understanding that we're talking about the sleep facility, okay, so where in-lab testing is done. And then it's also to make sure that we're addressing the safety of the patients and the workload of that staff member that is working at that sleep facility. And so when we think through kind of that 2-to-1 ratio then, and the fact that it hasn't changed with our new standards, then what we're saying is registered technologist or non-registered technologist, but the individual that's conducting the testing, that they still have a 2-to-1 ratio. Because if we begin to think about using a technologist that is virtual, well, if they're virtual, but the number of patients continue to increase, well, then ultimately means that you have a technologist that's on site, but they have more and more patients underneath them, more than a 2-to-1. Maybe they go up to a 4-to-1, or you begin to think about the extreme use case of that, right? Where maybe they have 10 patients that are at the sleep facility, but they have potentially 4 technologists remote. Well, that's clearly not safe for the patient, and does not is not safe for that technologist.
I had not considered that scenario. That sounds kind of scary.
Yeah.
And if I may, just to add on what Ray was mentioning, it was to have that virtual presence there in the standard. It would have been easy for one to think, as Ray was saying, one technologist, a registered technologist is present in a larger city and conducting, several polysomnograms, and at bedside, would be technologists that would not be qualified to fit any of the current standard registered technologist or non-registered technologist criteria. And we wanted to make sure that that will not be the case. I mean, the technologist at bedside will still be recommended to have the ratio of 2-to-1, and they would have to fit into the criteria of registered or the criteria of non-registered that are present in our standard.
So there's guardrails.
Yes.
At the same time, we are very aware that there's a lot of models of delivery. And so the accreditation committee, and I know Ray and his team, they're willing to hear from you. Everyone who's delivering sleep medicine care. I mean, if you're having a particular model and you're wondering, will that fit or not into the standard, please let us know.
I think that's such an important thing to recognize, that these are, created with the overall theme of we want to improve access to care while maintaining high quality care, right?
Mm-hmm.
And so I love the idea that there's, you're very good at humanizing this. There are people behind this that have really thought very deeply about this, but obviously can't cover every scenario. And so I love that you're very welcoming to, hey, if you're not sure if it fits, ask us, email us.
Yeah, and Dr. Jamous makes an excellent point there, because even when we think about the changes that we're doing with this new model, it all stems from the feedback that we've gotten from our accredited programs over the years. Yes, the standards are effective January of 2025, but we've actually been working on these standards since 2018. So we've been working on this for a very, very long time, but because it stems from the feedback that we're getting from our accredited programs. And so as we think about even what the committee's tasked with doing this year, it's looking at current standards or new standards that reflect current and emerging practices. So when Dr. Jamous talks about, please share your feedback, we understand that practices are going to evolve. We understand that technology evolves. And so for that reason, the committee tasked by the board is to look at these things to make sure that we can ensure that high quality care is being met, but then once again, removing those pain points, removing those barriers, so that we can make sure that accreditation, it's something that we have to do for payer requirements. We want to do it to be able to reflect the high quality care that we're giving to our patients. And so therefore it's also easy to be able to meet standards and demonstrate that we are doing these things.
Okay, so I have to admit something. I'm on the committee. I had no idea that you'd been working on it since 2018.
Yes. So it started development. I have a nice, wonderful timeline. The start of development was actually 2018. Then, as Dr. Jamous indicated, it went through a couple rounds of public comment period. So one from stakeholders, one from membership and our accredited programs. Each time it got reviewed by the committee, and then ultimately gets reviewed by the board, feedback. And so yes, there was a long time, a lot of involvement from the committee, from the board, from staff. And so we appreciate everything that the committee actually has done, because there's a lot of time that's been involved in it. And it really, once again, I do want to reiterate, it really is based upon the feedback that we've gotten from our accredited programs, and it really will benefit them, whether they are a smaller practice all the way up to a really large accreditation network.
So let's take a short break, and when we come back, we'll talk more about upcoming changes to AASM accreditation standards. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care Program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with members of the AASM accreditation team about some upcoming changes to the 2025 accreditation standards. So let's talk about computer-assisted scoring. Is that the same as AI scoring?
So a computer-assisted scoring, ultimately, when we're talking about computer-assisted scoring from a standard perspective, we don't really differentiate between, say, automated scoring versus AI, because AI is a little different than just automated scoring. So from a standard perspective, we're really just talking about when it is not being scored by someone who meets the definition of scoring personnel. So it's not being done manually. It is being done by automatically or automated, I should say. So a non-human component.
But then goes to a human.
Correct. So
Okay.
what the standard then indicates that if you're using computer-assisted scoring, that it needs to be reviewed by the human.
Yeah, we had to make sure that for, internally, like our watch pads, we had to make sure that they go to
Yep.
a tech and then to the physician. We had to change the workflow a little bit. So the verbiage changed too, right? Because didn't it used to say epic by epic and now it says verified and edited?
That is correct.
So what does that mean?
Ultimately, what it's doing is, once again, kind of removing a pain point. So when we think about computer-assisted scoring, it is getting better and better. I know there was a lot of discussion from the committee level on, is it good enough yet, where we can just kind of take out this whole aspect of review. Ultimately, what was determined is that it is very good, but it's not quite to the point where we don't think that it needs to not have a review. So that's why that the aspect of a review epic by epic was removed. So kind of removing or easing a bit of that pain point, but still making sure that it is being verified is to make sure that there is still that oversight through computer-assisted scoring.
Okay, because I wondered, some of the novel HSAT devices where you can't really easily review the raw data. So that's still a no-no, right? We still need to be able to review the raw data.
Still need to be able to have the capability to review raw data.
So let's talk about a change that I have to admit I didn't quite understand. So there was something in there about the diagnosis of obstructive sleep apnea by an advanced practice provider. What does this mean?
If we go back to the 2014 standards, there it was, epic by epic review of board certified of, the polysomnogram. And then in 2016, it changed into a verbiage where there was more emphasis on the diagnosis can be provided and who can provide a diagnosis based on a sleep study. And the whole epic by epic verbiage was removed. We felt that the most recent wording may be a little bit confusing. And so, following multiple discussions, what we ended up doing really is stressing the importance of the raw data review. But we did not put it in any particular standard. But it is there, on the second page of the standards in a preface within, a paragraph titled High Quality Patient Care and Management, where it is expected that the raw data will be reviewed and that the diagnosis is then provided based on that. The standards themselves just mention that the interpretation of the sleep study has to be performed by a sleep-boarded physician, and if not, a sleep-boarded physician has to review that interpretation. And so the diagnosis part and the raw data part were removed from a standard wording into kind of a general essence of what the standard should be and placed in the preface.
So an APP can combine the results of the interpretation with the clinical history and patient presentation and then diagnose OSA.
Exactly, based on a result of the sleep study. So the diagnosis can be provided by a licensed medical professional, and that is, usually dictated by state law, etc.
Yeah, I didn't realize that they couldn't do that before.
Yeah, and that kind of goes to a little bit about kind of the what is the current standard versus what is the new standard. So if we kind of just highlight the differences a little bit more. So our current standards are silent on the aspect of interpretation, but we talk about the diagnosis. And then in January, the new standards talk about interpretation, but are more silent on diagnosis.
Okay.
Okay, and so ultimately, what we think about the requirements of who can do these things ultimately somewhat remains the same when we think about diagnosis to interpretation. So the new standards are focusing on the interpretation, meaning the interpretation can either be or should be performed by a board certified sleep specialist, or at least is reviewed by the board certified sleep specialist, so that then when the diagnosis is being made, that diagnosis is coming from an interpretation that was either made by a board certified sleep specialist or reviewed by the board certified sleep specialist. So then now, whoever's making the diagnosis then no longer needs that diagnosis to have a review.
Gotcha. See, I didn't realize they had to do that before. So still, the interpretation is done by the board certified sleep specialist. That hasn't changed.
In the new standards, yeah, now we're focusing on the interpretation. We do a call out to that, where in our current standards, we don't actually even talk about the interpretation. So if someone is doing that at the moment, there's not a standard requirement that is holding them to
Okay.
one thing.
So what about some of the new models of accreditation? So what's changing and why is it changing?
So with the new models of accreditation, remember we're trying to, or at least the trend that we're seeing, right? If we think about, okay, this is all based upon the feedback from our accredited programs, so that means we have to identify the trends. The trends that we're seeing, and Dr. Jamous brought this up really early on, which is the fact that practices are evolving.
Right.
Right? So they are evolving. So when we identify the trends, what is becoming more prevalent are these larger health systems or these complex health systems, these medical groups. And so the standards are aligning with our accreditation networks. Okay, and so ultimately we'll have aligned standards with the networks. We will have a framework that supports the networks and is more modular based. And so from an application experience, then this will provide a more efficient and streamlined application process.
Oh, I like to hear that. So it'll be easier, not harder.
Correct. Yes,
Okay.
especially for the networks. So as they continue to grow, because remember they're all part of a same health system, or at least they're all associated. They operate underneath the same policies and procedures. It shouldn't be more complex if they need to go through an application process, because a lot of that information is shared.
Sure,
Right?
that makes sense.
Right.
Yeah.
So the application process will take those things into account.
Fady, do I understand this right? That the HSAT call log is gone now?
So for difficulties with HSAT, and so we call that the addressing problems during HSAT, standard. There's no need to document that, and that was removed in the new standards. Yes, previously it used to have to be documented and then have quarterly audits, but that standard was removed.
So, what about direct referrals and review of the clinical information? How has that changed?
Previous standards required that for every patient directly referred. So who are we talking about? We're talking about, so if I'm the sleep physician associated with a sleep lab, if I see a patient, that patient is not directly referred. But if a family physician in the community is referring someone to our lab, but that patient is not coming through our clinic, like what controls that referral is what we're talking about. So that's the direct referral. Currently, the facility director who would be a sleep-boarded physician, or a medical staff member of the sleep lab must review the information provided. So that means looking at the HSAT. Is there the right reason to do the sleep study? Has a previous sleep study done? I mean, are we ordering the right study? Meaning, I mean, have they already been diagnosed and all they need a titration, or have they never had a sleep study before? So right now there's that standard where a physician or a medical staff member would have to review that information. With the new standards, we're really doing what we think is very reasonable, which is we have very good relationships with our lead sleep technologists and our technical staff in the lab, and especially for home sleep apnea test. I mean, one can imagine how they will really know whether this is the right person to do the right test on upon review. And that's what we're trying to streamline and make it easier for the medical staff member, and maybe shift some of that responsibility on the trained technical or administrative staff.
So to me, that seems like you're eliminating one of those bottlenecks. I'm thinking about if I am out of town, right? I'll usually get an email filled with, all of these direct referral things that I need to review. So I love this idea of sort of looking at, I feel like it's looking at what a medical director does and what are the things that really kind of get held up if the medical director can't get to it right away.
Exactly. And what we expect is just, as you said, more expedient care. So patients aren't waiting. At the same time, I mean, having worked with our technologists, and obviously I'm sure, all of us have very good relationship with our technologist. I mean, they will know when to reach out. I mean, this doesn't sound like what we usually do. This doesn't sound, this doesn't have what we usually require, etc.
Yeah.
And so it doesn't mean that there will be no input from the medical staff or the director, but that hopefully it'll be more streamlined and care is delivered in an even timelier fashion.
So are there any other changes that we haven't talked about?
I can talk about the new administrative support staff.
Yeah.
And with the new standards, we did identify the administrative support staff as a new identity, if you'd like, in the lab. So this would be someone who can help with prior authorization, downloading compliance reports, maybe even providing the home sleep apnea test component without needing to meet the technical staff requirements of a CPR, A-step, etc. And so this is new compared to previous. What I think many sleep labs that are connected right now, but want to be part of a network accreditation moving forward, that they will be able to have the same quality assurance program. They will have to be able to share the same policies and procedures, and also the ISR, instead of having to have to duplicate all of these in the different labs and clinics right now.
Yeah, and if I may too, with what Dr. Jamous was talking about, and then with what you talked about as well, Dr. Kosla, we talk about the evolving roles of the practice, but the standards are also changing to account for the evolving roles of the individuals, the staff, right? And so when we think about the direct referrals, when we think about the administrative support staff, the committee thoroughly reviewed, how these roles are evolving, and then from a standard perspective, trying to enhance access for these evolving roles, the evolving roles of the physicians, of the advanced practice providers, of the technical staff, and the administrative support staff. And I do think that's also important to highlight. Yes, we have the evolving role of the practices, right? So practices are evolving, and so therefore, our framework, our model needs to change. But then within a layer of the standards, we are also trying to accommodate for these evolving roles as well.
Well, and that kind of makes me think about the sleep technologist change. And was that maybe because of the sleep tech shortage?
I can tell you that Actually, I was a staff member for the Sleep Tech Shortage Presidential Committee as well last year,
Ah,
and that was an identified pain point
mm,
that committee identified. Obviously, everybody's been affected by the sleep tech shortage. Some maybe in rural areas more than others, but everyone's been affected. And so, um, even though last year was when it was identified by the presidential committee, the accreditation committee was already working on a means to be able to try to improve access to that. And so it just
ah.
cohesively aligned with the aspect that, yes, this is an identified trend. Yes, we need to accommodate for it. And so therefore, then when it was also recommended by the presidential committee, it was easy to account for that, given that this is a means that's going to provide and improve, I should say, access.
So are there any other changes that we haven't talked about?
There are a number of changes, but on the ASM website, we have a standards at a glance that highlights all of the notable changes, and almost direct individuals to go to the website, look at the standards at a glance. That's going to do a call out to each section or each standard or each topic that is having a change, what maybe the current version of it is, and then how it's changing in the 2025 standards.
Well, and when we were preparing for this a week or two ago, I also learned that you can request a speaker for your state sleep society conference. So tell us a little bit more about this.
Yes, it is an initiative that the ASM does. So if we provide support to our state sleep societies, and so if you are interested, if maybe you are on a state sleep society, if you're interested, you can go to the ASM website, and underneath professional development, and then the subsequent heading is state sleep societies. There is a speaker request form that you would complete. You can indicate the topic that you're interested in receiving a speaker on, and then staff review that, and then look to be able to, within the academy, or maybe someone that a member that works within the academy, maybe they're a committee member or something like that, and we'll send somebody out in order to be able to provide a presentation on the topic that you requested.
I filled that form out like 10 seconds after I hung up with you.
I saw that, and then Thomas sent it to me right afterwards.
So any final takeaways for us, Dr. Jamous?
We're all in the business to try and deliver the highest quality care. And for sleep medicine, we have ASM, whose mission, is to do that. And one way the ASM is able to do that and help us is with accreditation. I'm undergoing my 4th accreditation with ASM and with our lab. I know that site visits can be, anxiety producing, but having gone through this process many times, I know that you all feel that this also is very educational, and this is really where it is. It is the standards are there to help us ensure the highest quality, and the staff at ASM are very helpful, helping us get the right policies, the right procedures, and standard by standard allow us to provide the highest quality care. If you are currently accredited as a lab or not, or if you want to expand and you're in a large network, those new standards are going to be easier for you to implement, possibly from a workflow, but also possibly financially. If you have a new model of healthcare delivery and your reach is bigger than maybe your physical size, reach out to us. There may be a role, there may be a place where those standards can apply to you. We realize as the accreditation committee that we may not that we there are some barriers still to rural communities, maybe integrated managed care, maybe research-based facilities, but we are constantly trying to improve them. So your feedback is really essential for us. The staff is great. Please use them. And we are constantly discussing different models, so please reach out to us.
How about you, Ray? What do you want us to remember about this episode?
Well, I'm going to reiterate what Dr. Jamous indicated because I think he hit that really well. So the only other thing then that I'll say is just to highlight what he said there at the end. Yes, please use the staff at the AASM for questions that you might have. I can't tell you how many times individuals will come up to me either at a sleep meeting or they'll send me an email or give me a call, and they'll tell me that the accreditation staff that have been working with them for the past 3 months, 6 months, 12 months, 18 months during the accreditation process really did their best and helped them along the process. A lot of times it starts with education on the standards. Right? And so we are there to be able to assist you. We are, in effect, a champion for your program to go through the accreditation process. We want to make sure that everyone is providing high quality care, and the standards is what holds them accountable to that. But we want to make sure you're able to do those things as well. And so we are there to be able to help you. And so please use us as a resource the application process, especially with the new model, will be really, really simple and efficient. And so we just want to say thank you for choosing the AASM as your accrediting body. Please continue to choose the AASM as your accrediting body. And we look forward to working with everybody as we move over to this new model of accreditation.
Well, thank you both for sharing all of these insights with us and helping us to better understand the new accreditation standards.
Thank you.
Thank you, Dr. Costa.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.